any acute symptoms. Looks as if his heart's kind of big here. He is a 47-year-old, so maybe some cardiomegaly, but surprising result on CT. Turns out that what looked like a big heart was really a fatty mass which hangs down from the thymus and has mostly pure fat with a few little streaks of more solid tissue. And so this is really another example of Thymolipoma. So this is a fatty tumor. These are considered benign lesions. And the characteristic is that they start in the thymus and they usually hang down from that. They're very soft, and so they just sort of drift down to the bottom, and they're slow growing. So the people tolerate them, and they need to be quite large. I showed a case 5 years ago that filled up most of the left hemithorax and had a convex top margin. I've seen ones on the right that blend in with the right heart border. This one blends in with the left heart border. So you think you're dealing with cardiomegaly or pericardial effusion until you get CT and see that what looked like heart tissue or pericardial fluid is actually low attenuation fat. So Thymolipoma, these lesions are usually asymptomatic, but they are associated with the same sorts of syndromes that other sorts of thymic lesions can be associated with, like pure red blood cell aplasia and even myasthenia gravis. So occasionally there are some systemic manifestations associated with this. But Thymolipoma, really nothing needs to be done unless the lesion is bulky and interfering with lung volume or something like that. This one is scheduled for resection. It's much more common to see a liposarcoma than it is to see a Thymolipoma. So everybody sees this lesion and think, well, how do we know it's not a low-grade malignancy such as a liposarcoma? This one is scheduled for resection later this month. Okay, so Thymolipoma, pretty distinctive.
David, are they thought to be like lipomas that just happen to gobble up some thymic tissue? Because they seem, the ones I've seen, which has been very few, are almost all fat with just some strands of tissue in it.
Like this one, right?
Yeah.
So I think it's thought to be really a thymic tumor. The thymus has fat in it, and when the thymus involutes, you're left with fatty replacement pretty much. So I think thymus, fat tissue is normal to have in a thymus, and in this situation, it just goes bonkers. But it's
okay.
I thought it's native thymic tissue that has the fat.
Okay. They're always really big, which is interesting. I mean, they're just so rare, but I know you've shown a few, and I think I had one years ago, but they always seem to be these big draping tumors, never little incidental things.
Right, and I think about 2 years ago, Seth showed one too, and was sort of hesitant about it, but it was clearly recognizable as similar to these, a soft lesion that hangs down that seems to blend with the heart and gets to be quite large. They get to be large because they grow slowly, and so the person tolerates them, and until they get to be quite big, they can make it hard to breathe because you don't have adequate lung volume. But the large size is very good for the slow growth. Okay, this woman is has a history of scleroderma and Sjogren syndrome, and has this radiograph here, which shows a tortuous aorta, some calcium here, nothing distinctive in the upper mediastinum on this AP radiograph, but it turns out that she has a thymic issue. She has all of this tissue here. It seems to be fairly soft, but it's not fat, and it's throughout the thymus here, and the thymus is applied to the pericardium. It looks as if she's got some pericardial effusion here too. So the pericardial effusion surrounds the heart down there. So people are very worried about this lesion, and she had complete thymectomy, and the diagnosis was
thymic hyperplasia.
So lymphoid hyperplasia, thymic lymphoid hyperplasia. So we know that lymphoid abnormalities go with Sjogren's syndrome. And I looked up some articles. There are several case reports of thymic lymphoid hyperplasia in association with Sjogren's syndrome, but also in association with scleroderma and other autoimmune diseases. So lymphoid hyperplasia of the thymus goes typically with autoimmune disease. And there was no malignancy, right? Can't really explain the pericardial effusion. It was not malignancy invading the pericardium or anything.
So a couple things, David. What worried people about it? Because when you first showed it, I thought it was going to be thymic hyperplasia for a couple of reasons. It involves both lobes of the thymus, and you can see the little lobettes or lobules of thymic tissue.
Yeah.
They drape naturally like normal thymus does, especially in someone with autoimmune disease. And I mean, an MR might have put that to rest. The other thing is her left ventricle doesn't look normal. It looks like the septum is disproportionately thickened, and I'm not sure if that's hypertrophic cardiomyopathy or if that's just we're catching just concentric hypertrophy from something else, and maybe that's related to the pericardial effusion.
Yeah, I think that's a good point. She's got a lot of other conditions too, including heart disease. So I think this is probably cardiomyopathy. I'll check on that and I'll put that in the history when I'll clarify that when I post this case. So I think that would explain the pericardial effusion. So I think what's good for thymic hyperplasia is how extensive it is, that it's on both sides. But I think that it's not uniform. I've seen some cases where it's very uniform tissue throughout the thymus, and this is scattered nodules and stuff like that. I can see how people would look at this, and then with the pericardial effusion think this has got to be a malignancy, and it looks as if it's spreading into some of the fat in the, it's spreading away from these masses. So I think people were uncomfy with this as just, plus her scleroderma was said to be burned out. I mean, it was supposed to be, that was old history.
Okay.
So that's not an active problem.
Yeah.
Her active problems, I think, are cardiac problems.
This might have been a good, but I think it's like when there's uncertainty, I think using just MR, this is one of the times when we found, it doesn't happen very often. I think we're pretty comfortable with most thymic lesions these days, but using the chemical shift technique can sometimes put us to rest.
Yeah, she did have MRI.
Okay.
On the basis of MRI, it was thought to be this was thought to be an epithelioid neoplasm of the thymus. I didn't show didn't load it.
Well, that
but they were expecting an epithelioid abnormality. So what would the signal characteristics be for epithelioid, Jeff, as opposed to lymphoid?
I don't know, because we don't do MR for thymomas. We do them for the rare times when we're not convinced it's thymic hyperplasia. It's more often we get referred a patient with a mass. We tell them it's normal thymus, but there's a report somewhere that calls it a mass, and just for peace of mind, sometimes for the patient or the surgeon, we'll just do an MR. But I would suspect for a neoplasm, you'd see some enhancement, and you wouldn't see the signal drop out between the in phase and out of phase.
Okay.
Yeah, but there's a nice thymic vein passing through there, right, too, that also argues that you're doing some soft tissue. So anyway, that's a nice case. And I know that histologically they make a distinction between thymic hyperplasia, which is an increased number of just the increased thymic tissue, and then the lymphoid hyperplasia, where you actually do get follicles. And I think the latter is more associated with autoimmune disease.
Yeah, and that's what I looked up when I looked up the autoimmune association. It was the lymphoid hyperplasia. Mm-hmm. And we know that Sjogren's is associated with lymphoid abnormalities in the lung, in the in the salivary glands, everywhere. It's basically a lymphoid disease. So to me, that should have the stronger association than, say, autoimmune diseases in general. But rheumatoid arthritis is and lupus are one of the commonly associated autoimmune diseases with thymic lymphoid hyperplasia. All right, this is a 68-year-old woman who has this 2020 CT scan that shows this rarefaction in the left lung base and an anomalous artery coming right off the aorta, big big sucker feeding this rarefaction in the left lower lobe. So this fits with sequestration, and some people would invoke this being a hybrid lesion here, representing a CPAM or something like that, or a congenital lobar emphysema, which is not always lobar. There are some calcifications. It would it would be expected to have atherosclerosis of this feeding artery. It's very common with sequestration. And then the calcification should be in the arterial wall, but these seem to be floating out in the airway. But within this lesion, there's this bubbly adenocarcinoma looking thing. So this was 2020, and it has this result. So people were worried that they recognized sequestration. They thought, maybe there's an adenocarcinoma hiding in the sequestration. She got a PET scan, which is not properly windowed, and it doesn't show any uptake down there. But with a sparse lesion, and with adenocarcinomas in particular, there is often, a false negative on PET. So this is not definitive. So another CT scan was done, and this is now we're up to 2021. So about a year later, and that lesion hasn't really gone anywhere. As a matter of fact, it seems to have sort of spread out. To me, it hasn't grown. The bubbles are bigger, but there seems to be the same amount or maybe even less tissue. It's not really behaving like an adenocarcinoma for sure. It's not a slam dunk. However, this lesion was resected, and there was no carcinoma. They also looked at a bunch of mediastinal and hilar lymph nodes. There was some scar tissue. There was some inspissated mucus, and there were some spiculated calcifications, or they said maybe even ossification down here. So this is probably dystrophic calcification. Maybe it's in dried up mucus, which can calcify, or maybe there's some inflammation that left behind the calcifications. It's a sequestration. There was a worry about cancer complicating it. We know that adenocarcinomas, rhabdomyosarcomas, and things like that can be associated with CPAM. So if you want to invoke CPAM for the rarefaction in this lung, you'd have to consider the possibility of malignancy within it. This was a false cancer concern, and it was just some scar tissue. Okay.
Have you seen? I know it's been described in the literature. I've just never come across one that had a cancer in it. Have you seen a cancer in a CPAM or other related lesion?
No, but I thought it came up once in our conference.
Yeah, it may have.
I thought maybe you or Travis brought it up for
Probably Travis. Because I don't recall having seen one. And the literature talks about it, and it's funny because we see them all the time in adults, and our surgeons are hesitant to do anything about it, unless if we see something growing. But like if we just find an incidental CPAM, they tend to not do much. They may scan them annually, but it's funny on the pediatric side. There's always kind of at least on some surgeons, a push to take them out because they could be cancers. And I've looked in the literature, and there's a lot of debate, and there's been some analyses, I think, I don't remember specifics, but there probably is a real but very small increased risk, and it probably depends on what series you look at. Speaking of hybrid lesions, when you just change the windows, it looked like I saw bronchial atresia in there, like a mucus-filled tubular structure. Yeah, like right there.
Yeah, I agree.
Yeah, and that's not surprising. There's bronchial atresia in a lot of sequestrations.
Well, basically, you have bronchial elements here that never link up properly with central bronchi. So it's not surprising that you're going to have some bronchi and they're going to have mucus in them. And when you have a cystic component to sequestration, it's basically bronchial tissue that's not linked up, and that is producing mucus, because that's what bronchial tissue is going to do. Bronchial epithelium is going to produce mucus. Mucus has nowhere to go to drain, and so it fills up and you get these spherical cysts, but those are spherical cysts that are attempted bronchi that never made it. So we can debate the nomenclature on these pediatric lesions all we want, but it does have bronchial elements in it. It's not surprising, and there they are.
Yeah, but it makes
Okay.
you wonder if the sort of the hit developmentally is the bronchial atresia, which then leads to abnormal development of the lung, and then those embryonic systemic supply of the lung tissue as it's mature, as it's developing, persist because there's not a normal pulmonary blood flow down there. I don't know. It's just kind of interesting to think about it that way because
Yeah.
um,
So
why else
you'd
would a
like
huge vessel
you'd
be
like the
down
bronchial
there?
problem to be the primary lesion. Okay.
Yeah.
Okay.
All right.
So lots of opportunities to speculate. Okay. So speaking of anomalies, here's a case of a homeless guy who's had several admissions for heart failure. I think he's got a lot of other medical problems. This is a radiograph that was contemporaneous with the CT scan I'm going to show you. It does have some nice septal lines here reflecting heart failure. Heart size is normal. I think it's thought to be an ischemic problem with his heart, ischemic cardiomyopathy. So the heart's not necessarily big. He's also got ascites, as you'll see in his abdomen. But the reason I'm showing this case is for this incidental finding. This was a PE study. It's got big pleural effusions, which we didn't see that well. But his pulmonary veins are interesting. So here's a big left pulmonary vein, which seems to drain into the center of the back of the left atrium. And if we follow that up, we see that one insertion is downstream from the upper pulmonary vein and the inferior pulmonary vein here. They join together and they plug into the center of the left atrium, and then they are joined by this vein from the right. So a common portal here, or ostium, for all of the veins on the left and one vein on the right. Now, this is not the only vein on the right. If we go farther up, we see three normal veins. So an inferior and a middle or medium, or whatever you want to call it, and an upper pulmonary vein. So the right pulmonary veins are there, three of them normally, and then we get this little accessory inferior pulmonary vein that joins the left pulmonary veins and plugs into the back of the left atrium. So I showed this to our cardiologist who's likes congenital heart disease, who rotates on our CT service, and he doesn't have a name for this condition. I'll bet you, I don't know whether Travis or Seth would be able to give me a name to this, but there's a common ostium back here, and maybe it's a form fruste of what the cardiology guy suggested. Maybe this is a form fruste of total anomalous pulmonary venous drainage, where all these veins would conflude into one source here, but then it should go into the right atrium rather than the left atrium. So veins are weird, and they're weird in the lungs as well as being weird systemically. They just sort of do what they want. Okay. Do you have a name for it, Jeff?
No, but I've seen some posterior confluences of the veins, but I
Yeah,
suspect that theory is it's along that thought with the anomalous drainage where there's a single trunk.
right. Okay, and let me show you one last case here. This is a case from the VA. It's a 58-year-old man who served in Afghanistan and maybe Iraq. I'm not sure about that. By his age, probably did. And he's got some heart disease. He's got aortic issues, as you can see here. And so this was really part of a cardiac workup, this CT scan. But there are some interesting findings associated with the airways. There's a little bit of airway thickening here of this intermediate bronchus, but then there are some weird calcifications down here. So we've got a little calcium here right on the edge of the airway, another one here. And if we go farther out, we'll see more of these calcifications. And some of them are slightly away from being bronchial cartilages. So my first thought looking at these things is that these are in bronchial walls. They're probably just bronchial cartilages. And so my question to Greg Kitsch, who sent this case from the VA, was, is this guy on Coumadin with his heart disease? Maybe he's on warfarin and stuff like that. That can lead to calcification of the airways, so that in men you can get a pattern of airway cartilage calcification that looks like what you commonly see in older women. So there isn't much calcium though in the main bronchi or in the trachea, so it doesn't really fit with that. And I thought, could he have amyloid? But I've never seen amyloid just confined to distal vessels like this. And then some of these calcifications are slightly away from the airway walls, and so it suggests to me they might be in lymphoid tissue. For instance, we've got one going here, which is not really right on the edge of an airway. The same thing's happening on the other side. A lot of these are right next to the airway, but some of them are slightly separate from the airway. And then if we go to a lung window, we see that these are not normal airways down here. They have thick walls. And these abnormalities of the airways, we see some bronchial wall thickening down here too, are mostly in the lung bases. It's kind of an expiratory CT, not intentionally. It's not clear air trapping in this. The upper lobes the airways are not quite normal, but the abnormality doesn't seem to be as bad as it is in the lower. I don't know his smoking history. I do know that in his service in Afghanistan or Iraq, he was exposed to dust storms and to burn pits. So I suspect this is going to be related to his service. Here's another one of those little calcifications. So my question to you is, do you have any explanation, Jeff, for these calcifications that are around the airways? Some of them, I wish I could show you a convincing example, are slightly away from the airways. There's a little separation from airways, suggesting that it could be in nodes.
Well,
could you see the inhaled dust? Could you see this with, is it just dystrophic calcification? He's got mild renal failure. I've never seen metastatic calcification in this distribution. Any thoughts?
I have some ideas. I don't know if there's any truth to them, but burn pit is mostly gases and particulates, and I would expect to see air trapping, emphysema, stuff like that. But the dust storms is interesting because you can imagine if you inhaled some fine grains of really fine sand, it would almost incite like a foreign body reaction. And if it lodged in a small bronchus, you could see that might account for something. Or alternatively, you're seeing there's smaller particulates that we can't see, but they're accumulating in tiny lymphatics near the airways. And that might explain the proximity, but I can't prove that. It also could be from some sort of granulomatous infection as well. But it doesn't look like the typical histonodes we see, where they're usually at the bifurcation of airways.
And I would think that the dust storms ought to resemble silicosis. So I would expect to see predominantly upper lobe disease, especially on the right, and not basal predominant stuff. I would expect to see some lymphadenopathy and maybe some calcium in mediastinal nodes. Now, I don't know whether these are just little vessels here or whether these are some of our calcifications. Maybe these are not vessels. Maybe those are some mediastinal nodal calcifications. Okay, so it doesn't look like the typical inhalational thing because those are usually upper lobe.
Right.
And silicosis would be the closest thing. Now, the burn pit thing, I was reading some literature on that yesterday. Surprisingly, they have little air trapping on CT scans. It's not a reliable finding. They have abnormal pulmonary function tests, but they don't show air trapping on CT. However, the articles I was reading didn't show a lot of CT scans for me to get an assessment of how good they would be at determining whether there was air trapping or not. But they made the point
go ahead.
that air trapping is not a reliable finding on CT scans in the burn pit people.
Yeah, and it may be that they don't. There's more particulates. I mean, because it's not a confined space like you see with a house fire. I mean, we've seen cases of constrictive bronchiolitis occurring from a single exposure, like a single house fire, I think, or single event, whereas
Right.
the burn pit is, and who knows what's in those when they're burning stuff, what's being particular, but they're outside. So it's hard to,
Right.
and there's probably not all the same disease, right? Depending on where they're at, how long they're exposed. But
What was burning that? Right.
yeah, but the ones
Okay.
I've been
So this.
shown of of of, of veterans who've been exposed to burn pits, I've been underwhelmed as well with the findings.
Okay. Do you remember where they had this much lower lobe disease?
No, I don't. The problem is they're
Okay.
always, a lot of them were confounded by emphysema and other smoking related changes.
Right. Okay. Those are my cases.
Great, those were really cool. Okay, let me see if anybody else joined. Nope. All right, I will show some cases. I don't think mine are going to be as exciting as yours, David. Okay, so this is a woman who had a CT scan, and you can see there's an abnormality here in the left pulmonary artery. And a couple things I want to point out. First of all, it's really big, and it's filling the entire left pulmonary artery. You also notice it's kind of got this convexity towards the outflow there, and this little shelf to it. And as we go down, you can see there, you can see some either little tiny streams of contrast running through there. There's a bronchial artery here as well. It's not huge, but there's definitely some collateral flow, and we can see just a little bit of heterogeneity in there. Some of this is noise. And then beyond that, you can see there's this mass here. And then coming in, there's the pulmonary vein. You can see some smoke artifact, but just above it as well, there's looks like a big bronchial artery coming into this. So the question always is this a PE? Is this a primary malignancy? Is this an in situ thrombus from obstruction, or is this all tumor? And you can see there's been a mastectomy here. So this is actually a giant, and some of this is probably obstructed lung, but there is a metastasis into the lung that has invaded the pulmonary artery and is growing growing this way here. So this is not a pulmonary artery sarcoma, but rather a MET, which is probably more common than a pulmonary sarcoma because they're so rare. I haven't seen a new case in many years, but just a nice example. And then you've got distal obstruction, but it can be hard to sometimes sort out where the tumor is. But the important findings is when you see these filling defects that are this big, you always have to wonder, is this thing really acute? Because most of the big clots we see kind of drape over, and because there's blood getting by them, you don't develop acute cor pulmonale. And this patient has had time to adapt to this. And so you may see bronchial artery collateral flow in there as well, which can be helpful as a sign of more chronicity. And this isn't typical of a chronic clot you would see with CTEPH. However, you can get in situ thrombi in patients with pulmonary hypertension, but they typically are eccentric and look like just long adherent clots. Okay, this is a little companion case to your vein case. So this is a woman who came in short of breath, has a history of COPD and sort of decompensated, has some other chronic medical issues. And you look at the radiograph, lungs look a little loosened up here, but nothing strikingly abnormal. So she had a CT angio done. And interesting, she had some previous scans, but a lot of them were compromised by motion or they were non-contrast. But first thing you'll notice is there's a lot of collateral flow here. So I always teach my residents, when you see a lot of collaterals, you have to work out why, because I showed you guys a case last week where you had pseudo metastases from collateral flow. I've seen cases where there's a big mass, there's trauma, there's a thrombus. But in this case, there's a lot of collateral flow. But what we'll notice is there's a very narrow AP diameter of the chest. And if you start, and there's the azygous vein. So if you start looking for the brachiocephalic vein, you see that it's really tight and there's a lot of collateral flow. So it's either thrombosed or it's thread-like. So that's a decent explanation for it. But what was kind of cool is one of my residents who looked at this first picked up on an interesting anomaly. So first you'll notice the pulmonary arteries are a little bit big. And as we get down to the heart, we'll notice that the right atrium and the right ventricle is dilated. So there may be some findings of pulmonary hypertension, or at least some right heart dysfunction. The IVC is really big. But what the resident also noticed is this little guy here. You see there's this vessel that's draining into the inferior vena cava, and we can follow it up north. And it sort of hugs along the mediastinum, and then it goes up north into the upper lung here. So this is a pulmonary vein. So this is a scimitar vein, but what's kind of interesting is it's draining the upper lung, and you'll see there's a normal inferior pulmonary vein, but there's no superior pulmonary vein on the right. So we've seen a lot of scimitars, and we did a poster for the European Congress, I think it was 2016, and we kind of compiled all our cases together, but I don't recall seeing one where the scimitar vein drained the entire upper lobe, but didn't really drain any of the lower lobe. And this one also is very sneaky, because most of the time they sit in the middle of the lung, and you can see them on the radiograph. And then this one just hugs the mediastinum and goes right in there. So understandably why it was overlooked on non-contrast studies, and could easily be missed if there's a lot of motion artifact in that area. So along with scimitar, of course, there's other anomalies, most commonly being the airways. So it's important to look at the airways. And so here we are at the trachea carina, and we'll notice we go right to the bronchus intermedius. Now it's being compressed by this big pulmonary artery, the narrow diameter. She's also expiratory, so multiple things going on there. But there is no right upper lobe, bronchus. And then we get down here, there's the bifurcation. We've got middle and lower lobe. And you'll notice that the lower lobe, the lobation is also abnormal. We see what looks like maybe three segments, a lateral, anterior, posterior, and a medial. We don't really have a lateral. And then the middle lobe as well is just a single bronchus here. We don't really see, we see maybe a separate segment coming off, and sort of a funny pattern, and there's really not a lot of separation between the two. The left lung, interesting, has these weird cystic spaces in the bases. I don't know how to explain that, and just some atelectatic lung down there from compression. So other anomalies you can see are systemic arterial supply, diaphragmatic defects, duplications, and then other forms of congenital heart disease. So she's in her 70s, and this had been a silent lesion, so no trouble for her whole life because of this, but because she's having some other issues, COPD exacerbation, I think she had a component of heart failure, and just not air rate, moving a lot of air. This small shunt is becoming more significant. They don't plan on doing definitive therapy, but it just makes things a little bit trickier now. But kind of an unexpected finding of a scimitar that when you go back to the radiograph, you can't see the scimitar at all, because it's tucked in right here, running along the mediastinum. So that's an unusual one. The classic ones tend to start out here and go down like this, and they get bigger as they receive more veins, but this one is only draining the upper lobe. So there is that relative lucency, and I guess I should show that parenchyma again. You look up here, and really it's not hypovascular at all. It's just a slightly smaller lung, but you don't see that mediastinal shift like you often do. So a scimitar with a two-lobed right lung, and a very funny scimitar vein. Okay, this is a young person who has a diagnosis of HIV and was noted to have, somewhere in here, there we go, to have a lot of lymphadenopathy, and I'll show the abdominal CT, and you can see there's, I'll go up a little higher, there's some big nodes here in the retroperitoneum, but the biggest nodes are way down low in the inguinal region, and you can see there's also a lot of iliac nodes out here as well. But these inguinal nodes are quite large, and you notice they're enhanced quite a bit, and there's a lot of them. So they did a chest CT looking for other causes of lymphadenopathy before they decided to sample tissue, and we can see there are some big mediastinal nodes, not huge, but more than we typically would see. Although with HIV, you can get generalized lymphadenopathy. Probably some remnant thymus tissue, nothing really accessible external to the patient, but sort of starting to get a sarcoidy look here as far as just the distribution, lots of bilateral mediastinal hilar lymphadenopathy. And then if we look at the lungs, we can see there are lots of nodules in the lungs along the bronchovascular bundles, just some thickening in there you can see as well, like example there. So all in the lymphatic distribution, but this patient has HIV. Even up here, you can see some perilymphatic nodules. There's also a few septal lines, and that goes along with that lymphatic distribution. But I'm not a big fan of this for sarcoid. I mean, it could be, but given those big nodes down in the pelvis, more septal lines here, yet there's no vein involvement. You have to think about other things. So, and one thing on the list that they were concerned about was Kaposi sarcoma. They almost always have skin lesions when you see it in the lungs. And then we threw in for completeness multicentric Castleman disease, because that can be associated with HIV, and they can get lymph nodes. They can also get a bunch of other things, but they ended up biopsying one of the inguinal nodes under ultrasound, and this is all Kaposi sarcoma. And the presumption is the lung findings are all related, which would fit with those big nodes. So I don't see too many cases of this. I haven't seen one in a long time, but this one's interesting because I think if you didn't have the story and you didn't have the abdomen, I think it would be very tempting to call this sarcoid. I don't know if you agree or disagree, David.
Yes, or some sort of mild infection. It's the long airways, and there's a little bit of airway thickening.
Mm-hmm. And I suspect that's all tumor cells along the lymphatics. But the classic description is sort of that flame-shaped or shaggy look. And I've seen that a couple times, but I've also seen some KS that's less shaggy looking.
Right, and often it's just lung nodules, and you can't make anything specific out of them.
Right. Yeah. It's still out there. It's not very common, but be aware.
Did he have skin lesions?
I believe he did, yes. I think that's why they were concerned about KS in particular. I was wondering if it's going to be Castleman, just given how dense those lymph nodes were. But I guess Occam's razor won here.
Yeah, it would have been, but he's entitled. With HIV, you can have as many diseases as you please. But it would have been interesting to see if those mediastinal lymph nodes lit up with contrast. Yes.
Okay, I can't remember if I've already shown this case, so if I have, my apologies. I don't have a record of it, but I lose track pretty quickly. So I wish Seth were here because I think he'd like this. So this is a case of chronic pulmonary thromboembolic pulmonary hypertension. We can see there's this extrinsic clot. So this is a good companion to my previous case, where you could see that big tumor thrombus. This is nice and smooth. It's along the side there, and then we see dropout distal to it. So a nice example of CTEPH, and you can see on the lung windows there is mosaic attenuation, not the prettiest. It's confounded by emphysema. But what's interesting, and that was a while ago. This is on a follow-up scan, and what's interesting is all of this collateral flow that has developed. And you can see most of these are systemic veins. You can see they're all in the region of the SVC. We don't see any collateral in the chest wall, but you can see how big the SVC is. I suspect the right heart pressures have gotten quite large. The azygos is plump. But what's kind of cool is if you watch where these go, so they go along the hilum, and then this one dumps into the left atrium. You can see a little jet of contrast. So what I suspect is going on is the pulmonary hypertension has clearly gotten really bad. We see big right atrium, dilated right ventricle, compression of left ventricle, is that there is elevated, so the right heart pressure is so elevated that these mediastinal pathways have opened. And so these are draining into bronchial veins, and probably veins, and maybe then there's some cross communication, and maybe these pathways are normally closed for whatever physiologic region, but the contrast is trying to get somewhere, and it takes the path of least resistance, and it's going in here. So it's creating a right to left shunt, which is not great when you already have pulmonary hypertension. So now you're sending deoxygenated blood into the systemic circulation. But it's kind of cool. You get a white smoke artifact, and you can see one down here as well. Maybe a hint of one over there. That could be an artifact. But you can see there's nice webs. There's dilated vessels. Some of the pulmonary arteries are quite large. There's eccentric thrombus. You get a black smoke artifact here. So I thought that was kind of cool. I haven't noticed that before. These pressures, I presume, are quite high. There's even some reflux back up the out of the coronary sinus into the great cardiac vein up here and its branches. So I don't know what you think, David, but do you think it's a plausible theory?
Yes, I like that theory. And, going along with that is what we've seen in some people who have esophageal varices, where you have those systemic veins under high pressure, very dilated. Sometimes they drain to inferior pulmonary veins.
Mm-hmm. I've seen that for sure.
Can try to decompress into the pulmonary vein circulation.
So I suspect these are probably pathways that are developmental, and they're just closed because there's no driving flow, because the left atrial pressure is usually higher than the right,
Mhm.
so there's no reason for blood to go there. And then because this is not an acute event, has been developing over years, those pathways start to open up again, and blood will take the path of least resistance. But it's very interesting when you look at cases with mediastinal collaterals, how many vessels there are that if we on a normal CT, often you just see fat in here and a few lymph nodes, and how you can have
Right.
all of these channels. And so they have to, I don't think they're recruited there. I mean, they've got to be pre-existing. It's not like there's angiogenesis. I can't imagine that. I suspect that these are always there. And I remember years ago seeing some cases of even coronary arteries communicating with bronchial arteries. I think I saw a case when I was a fellow, and I don't think people knew about that. At least most people didn't until we started doing coronary CTs in the early 2000s. So
Mhm.
there's some interesting pathways, but this one was quite impressive. I kind of liked this case, and it's a good smoke case too because it has white and black smoke in it. And maybe next time Seth's on, we'll ask him if he's ever seen this because they see all those CTEPH patients there.
The interesting thing is that the pulmonary vein pressure is probably extra low on the right side where most of these collaterals are, because that's where the arterial obstruction is
Right.
greater. Um, so maybe that's, maybe it's almost a vacuum in those pulmonary veins is just sucking in collateral circulation.
Yeah. I mean, there's another one right here coming in. I just noticed right there. See this little jet coming off this, going into this left
Yeah,
vein. But you're right, because look at the size of the left lower lobe pulmonary arteries compared to the right. So yeah,
yeah.
most of the blood flow is going to the left. So that makes perfect sense that the venous pressure would drop on this side, allowing preferential drainage of those collaterals. Okay, I think that is all I have. Have I shown them all? Yes, those are my 4 cases.
Perfect.
So great discussion, David, even if it's just the two of us. All right, well, hopefully
We're
we'll be back next week.
all right.
Take care.
Thank you, Jeff.
Yep, thank you,
See
David.
ya.
Bye.